switch gears a little bit to the ICD, arrhythmia detection and therapy, by Dr. Gaurav Upadhyay, who is an associate professor of medicine at the University of Chicago. He received his MD from the University of Chicago and did his internal medicine residency at Mass General Hospital. He was a chief resident at Newton Wesley Hospital, and then back to Mass General to do both his cardiology and EP fellowships. So, Upadhyay, it's all yours.
Thanks so much, Ralph, and thank you, Mitzi. Gurjeet, that was a masterful presentation. I think that, certainly you've set the stage here for a lot of complexity that hopefully we can get into. And before launching into this discussion on ICDs, I just wanted to get a sense from the group here, if you can use your chat box and just tell me, are you guys first-year cardiology fellows, second-year fellows, third-year fellows, if you can just kind of write in where you are in fellowship. Or if you're a resident, if you're a first-year resident, second-year, third-year, just to get a sense of kind of the audience here. So great, so we got some first-year fellows, some incoming fellows, third-year, second-year, awesome. Residents, a couple of fourth years, chief residents, terrific. So it's a big group, so we're going to be covering sort of a range, and some of these topics might be very straightforward to those of you who've seen devices, and others, this might be completely new. And as much as possible with Zoom and with the limitations of Zoom, I want to try to make this interactive. So I'm gonna take a slightly different tack, and I'm gonna suggest when we get to ECGs, I may ask a question, and if you'd like me to ask the question to you, I will offer up like a promise it'll be fine. We'll be super gentle on everyone. Just turn on your camera and we can have a conversation. It'll be Vegas rules here. Okay, so we'll get set in the Zoom, stays in the Zoom. So you don't have to worry about that, but it might be nice to interact on some of these tracings. And certainly I guarantee it that if you have a question, someone else will have one as well. So with that as a backdrop, let's talk about the agenda for this evening.
This is from, where did you buy this?
I'm not sure where you bought it, Mr. Francois. This is, I hope it's someplace really good. Just teasing there. Historical milestones, we're going to cover that. Defibrillator function and programming and examples of stored events. So milestones and defibrillation. So this is a very, very different technology than pacemaking. So defibrillation fundamentally has to do with interrupting an arrhythmia, whereas pacemaking fundamentally has to do with sustaining a heart rate. And there has been really tremendous development in defibrillation over the past century. And some of the earliest investigators that deserve a fair amount of credit is this gentleman here. His name is Kai van Hoven, and he was actually a PhD in electrical engineering at Hopkins. And the term countershock.
I'm sorry to interrupt, though. I'm kind of still seeing the first slide. Are you in presentation mode, or?
Yeah, I'm in presentation.
Is it just me that I'm having a problem, or?
Let's see here.
Not just you.
Is it just you?
No.
No, not just you. Okay.
There we go. If you can kind of put it on the slideshow, there you go.
Do you see it here?
Yes.
Okay, great. So here's Kai van Hoven. Does everybody see that?
Yes.
Yes.
Perfect. So Kai van Hoven was a PhD in engineering at Hopkins, and he is actually the investigator who first introduced the term countershock. So countershock, the idea was actually first recognized in the late 1800s that an electrical current could induce ventricular fibrillation. But how to interrupt ventricular fibrillation was not known, and it was actually an accident. So Kai van Hoven came out of engineering school and was looking for work, and this was in the 1920s when the electrical system of the United States was actually being developed. And relatively small voltages, when exposed to people working on these power lines, could lead to VF. And so those relatively small voltages were killing people. So the electrical companies had a vested interest in trying to figure this out. And so they hired investigators at different universities, including Hopkins. Kai van Hoven was doing that work, and in canines, he discovered that relatively low voltages could induce VF, and that a countershock could then make VF go away. Okay, so he not only made that observation, but his team at Hopkins later went on to describe pretty much the fundamentals of CPR. So we owe that really to Kuyvenhoven. The first description of defibrillation was actually reported by Claude Beck at Case Western University in 1947. And this was the original defibrillator. And he actually, it's notable that he used this device because this approach of fibrillating had actually been first reported by Carl Wiggers. As some of you might remember the Wiggers diagram, who's also a Case Western. And Claude knew Wiggers and kind of worked in his physiology laboratory, was doing a case on a 14-year-old child. And at the time, if people were having trouble coming off of pump, they would perform open cardiac massage. And so this kid had a reasonably uncomplicated repair of a pectus. And so, I mean, they're really were not expecting a lot of trouble and went into VF. And they performed open cardiac massage for 45 minutes. And it was only during this time that someone went down to the animal lab, got this device, and then they were able to defibrillate it. And they published this experience in the New England Journal of Medicine in 1947. And it's really important here that this was the first time that people were able to interrupt an arrhythmia that previously was completely mortal. I mean, this is a lethal arrhythmia. So it was really at the sort of the birth of cardiac surgery. Around this time, work was also being done in the USSR. Noam Gorovich made the observation that you could defibrillate humans externally. And this is actually an early external defibrillator. And Paul Zoll, whose namesake is the company who's sponsoring this evening's session, actually reported on those results here in the United States. He actually had an AC current defibrillator in 1956. It wasn't until 1980s, though, that automatic implantable cardiac defibrillators were used in humans. And this is an early device. And it used to be, and you may still find some people refer to these devices as AICDs. The A stands for automatic. And we owe that to Morton Maurer. And here, do you see my mouse here on to Michel Morawski? Michel Morawski is an amazing figure. His family fled the Holocaust from Poland when he was a child. He went to medical school in Paris and then worked in Israel. He had a mentor by the name of Heller, who had an anterior MI and would have ventricular tachycardia. And the ventricular tachycardia, in fact, could be interrupted with an external defibrillator. And in fact, it was the job of a house officer to follow around Dr. Heller and defibrillate him if he went into VT while he was in the hospital. It was unfortunate and sad that Dr. Heller died at home at dinner when no one was around. And so that really inspired Dr. Morawski to come up with an approach to identify and treat arrhythmias without requiring human intervention. Amazingly, at the time, they thought that this would be unethical. And one of the giants of the field, Bernie Lown, who is really credited with popularizing the movement to CCUs, talked about the ethics of doing this sort of work, which is, remarkable in consideration of just, what Dr. Morawski had and his own sort of personal struggle. It was actually another investigator, Art Moss, who sort of came to his his rescue in a series of editorials published in Circulation. So most recently, the most recent iteration or a progression in the world of defibrillation has been subcutaneous defibrillators in 2010, which incorporates many of the advantages of automatic implantable cardiac defibrillators, which are primarily transvenous today. So again, in a nutshell, pacemakers sense intrinsic activation, deliver on-demand pacing, and defibrillators sense and identify arrhythmias. So one is a metronome, and another is more like a fire extinguisher. So those are the two paradigms here that we're getting into. So pretty straightforward here. This is a single chamber device. And the question for the group, which one is the defibrillator? Is it the one on what I'll call here the left of the screen, or this here, the right of the screen? Good. So if you got all of you guys are picking up onto the fact that the defibrillator here has a shocking coil. So that's what very quickly, even in a chest x-ray in the emergency department, you can use to identify a defibrillator. Here, another example, variation of the same theme. Here is a dual chamber defibrillator versus a dual chamber pacemaker. And then this is a biventricular device, same idea. Entirely subcutaneous, slightly different. There's the subcutaneous electrode, and importantly on the lateral film is above the sternum. So again, nothing transvenous for a subcutaneous defibrillator. And importantly, it is not able to pace. So that's a limitation of that device. Well, what about defibrillator function and programming? How do these devices work? Well, the purpose of an implantable cardiac defibrillator is to sense arrhythmias, to classify them, to determine if they're ventricular or supraventricular, and to deliver appropriate therapies, either shocks or anti-tachycardia pacing. Finally, they're actually quite helpful at storing diagnostic data, and there might be an evolution in coming years about using the diagnostic data that's being acquired by these devices. So here's some of the components. There's a capacitor and a battery, a header where the leads go in, and a small amount of circuitry. Leads, and this is an example here of an Abbott lead, will have multiple different cables. There are both conductor cables as well as cables that are carrying the high voltage energy to the defibrillator. The defibrillator shocking circuit may be between a shocking coil in the heart and the can, or may also involve an additional coil here that's placed in the SVC. What the defibrillator is viewing, or what it's seeing, is a depolarization wavefront. So let's just take a second here and look at this. The tip of the lead we term as the cathode. The ring we term as the anode. And if a wavefront is traveling in this direction, the cathode would first see it as a positive, and as it travels away, it would be a negative. So it becomes negative here. The anode sees it later, but again, it's the same idea, positive, negative. But we sum the two in order to obtain an electrogram. So this is actually how the device is seeing electrical wavefronts. And in EP, we talk a lot about near field. So something that we think is in relative close proximity to our recording electrodes, and far field, meaning that the recording electrode is sensing an electrical event, but that is further away from immediately adjacent to. This electrical signal goes through an amplifier and then a series of filters before it meets a detection threshold set by the device. So broadly speaking, we could sense either between the tip, again, cathode, anode, and the ring, or the tip and a coil for a defibrillator. And both have been used. When we talk about timing for pacemakers or defibrillators, we have to have two events. So here, VS, that's just a V-sensed event. And the timing requires two contiguous events. And really, it's that notion of timing between events that a number of the algorithms that Gurjit just went through takes advantage of. So here's an example of ventricular tachycardia. And just to orient you here, we got an atrial electrode and then the ventricular electrode. And clearly there are more V's than A's, and they're quite regular. So it's most likely a monomorphic ventricular tachycardia, at least according to the near field signal. And you'll note here that that atrial electrode, in addition to seeing the atrial electrograms, also sees the V. Does everybody see that there? It sees small deflections, which are almost certainly the V. And the question is well, why is it even seeing the V at all on the atrial channel? So I'm going to throw this one out to the group. So why do you think the atrial channel here is seeing the V? And if you'd like, we can do Vegas rules here, and I'll call to someone whose camera is on. I just need a shaking of your head so that you're okay with this. Okay. All right. So Eaton, what do you think? Why do you think there's something seen here on that atrial channel?
I mean, it could be, is it far field sensing?
Perfect. That's exactly right. So it's far field sensing of the V. And the question is why would an atrial lead ever sense the V? I mean, it's like in a totally different chamber.
I'm not sure.
So great. So this is a really tricky question. It has to do with how these chambers are in such close proximity in the heart. So a traditional placement for the right atrial lead is at the base or inside the right atrial appendage. The right atrial appendage sits immediately adjacent to the right ventricular outflow tract. It is not uncommon for that atrial lead to pick up signals that are going to the right ventricular outflow tract when sitting inside the atrial appendage. So you're more likely to see far field sensing of the ventricle when you have an atrial lead that's in the appendage versus, say, at the lateral aspect of the right atrium. But it's a great example of how the geometry of the lead placements can impact sensing, can also impact when there are errors in arrhythmia detection. Okay, so this is that same patient, and we see here the delivery of a charge of 24.6 joules, and then a big change in the arrhythmia. Okay, so anyone, I mean, I've kind of spoiled it here. We call it ventricular fibrillation. This is not uncommon, where the shock itself has changed a regular monomorphic ventricular tachycardia to a much more coarse and irregular rhythm, ventricular fibrillation. So ICDs take advantage of counters to try to identify when arrhythmias are present. So in most devices, there's a type of counter called a consecutive counter. So it's just looking for one interval and then another interval. And it's simply timing. And if a number of intervals are fast enough, and here NID stands for number of intervals to detect, and here it's set to 16. So 16 intervals that are fast enough in a contiguous fashion would meet the criteria for the device to say a VT is present. Another approach is to use what's called a probabilistic counter. So a probabilistic counter doesn't look at necessarily contiguous intervals. It's simply saying, do any intervals meet the criteria of interest within a window of interest? So here, the number of intervals to detect is 18 out of 24. Any 18 intervals meet a particular detection criteria within a moving window of 24 intervals, then it would satisfy detection. And that's much more applicable for irregular arrhythmias such as VF. And of course, VF is the one we worry about the most. So here's an example of a patient with an irregular tachycardia that is fast on the ventricular channel. And the device is counting VSs. And once it satisfies the criteria, a charge is delivered. And there's a shock and then return of rhythm. So that's where the shock occurs. And you'll note there that when the shock occurs, there is some sort of change here in what the signal looks like locally. So there is charge sometimes that's residual on this, on the sensing electrode, which can change how the impulses look here, but doesn't necessarily affect the atrial channel. Well, what are other forms of therapy? Well, here's one. So I'll ask if Ahmed is okay with this. So what's happening here?
So there's atrial channel, ventricular channel. The ventricular channel is sensing tachycardia. with a far field sensation also in the atrial lead. And then after a certain period of time, seems like the pacemaker is overtaking.
Good. So you're noticing here that the device is seeing this arrhythmia and it's categorizing F sense. F sense here means that the rate is in the ventricular fibrillation zone for this type of device. And then here you see TP. See these markers? And this is a really, really, really important point. Whenever you look at device EGMs, whenever you look at those EGMs, the device can't see what you can see. The device only sees what it notes. Does that make sense? So you very quickly were like, oh, wow, there's far field ventricular activation that I see, that you see with your human eyes on the atrial channel. But the device, the way it's programmed, it doesn't see it except for right here. There's an atrial blank and an atrial refractory. Otherwise, it doesn't see those signals. You see what I'm saying? So the device only sees what it marks. And here we have TP, or tachycardia pace. And so this is another type of therapy that the device has in its armamentarium besides the shock. So it's delivering anti-tachycardia pacing. So it delivers anti-tachycardia pacing. That anti-tachycardia pacing was in fact successful, and the arrhythmia terminated. And then after the arrhythmia is over, we see ascents by the pace. Everybody with me there? So here in this example, anti-tachycardia pacing was enough to terminate the arrhythmia. And obviously, one hurts more than the other. So if you can utilize approaches that don't require a shock, it would be beneficial. Now, a fundamental problem that often occurs with devices is how to distinguish between SVT and VT, because both of these arrhythmias have a very similar rate. So if we think about rate alone as a discriminator, it may not be able to distinguish these two arrhythmias. And unfortunately, rate is the most commonly used tool, and in fact, probably one of the most important tools that we have to identify arrhythmias, and that can lead to inappropriate shocks, particularly when you have atrial fibrillation with rapid ventricular response. So here's an example about the prevalence of inappropriate shocks can be quite dramatic. In Scud-Heft, 17.4% of shocks were inappropriate, and MADE-2 is 11.5%. In AVID, 32% were inappropriate. So 32% of the patients had received inappropriate shocks. And then of the percentage of total shock episodes, we have a little bit more data. 31% of the total number of shocks in MADE-2 were actually inappropriate. So there has really been a revolution in terms of how the devices can take this into account. And the reason is because inappropriate shocks, even by themselves, may be associated with an increased risk for death. Simply being shocked has been associated with an increased risk for death. Now, we're once again back at a fundamental problem. How do you tell a device, a machine, what arrhythmia is present? So here, this question is going to go to Laura. So Laura, what arrhythmia do you think is present here?
Looks like AFib with RVR.
Perfect. So terrific. And how did you know that?
Because the A-tip to A-ring is showing impulses that definitely look less than 200 milliseconds. And then the ventricle is showing irregular R-to-R intervals.
Awesome. And here we see the device is actually telling us, oh my gosh, the atrium is going 130, 140, 140, 150, 160. It's incredibly fast. I mean, 140 is like a heart rate now that's approaching 500 beats per minute. And then the ventricular intervals are also very fast and very irregular. So how do we think about SVT discriminators? Well, there are a couple options we could use. These are three different ways to examine an arrhythmia. One is to say, well, let's look at the onset of an arrhythmia. An arrhythmia like ventricular tachycardia should start like that. It shouldn't have a smooth slope up. If something has a smooth slope up, it's much more likely to be a supraventricular arrhythmia. What's another approach we could use? Well, we could ask the question, what's the relationship between the P and the R waves? If there's a one-to-one relationship, it is less likely to be ventricular. What about the morphology? Could we take advantage of the morphology that's present at the ventricular electrode? And finally, stability. You know, if arrhythmia is incredibly stable, it is more likely to be a monomorphic ventricular tachycardia than an irregular atrial fibrillation. So more of these morphologies among the most powerful. And we can take advantage of the electrogram that's actually stored in the device. So here we have two examples, normal sinus rhythm, ventricular tachycardia. And at the start of both tracings, the device can examine or can analyze the waveform between the can and the RV coil. So that's between something in the chest here and something in the heart. So it's like a pseudo surface electrogram. And there's a big change in the electrogram for ventricular tachycardia. Wavelet is a discriminator that's used by Medtronic, although all the vendors will have a type of algorithm similar to this, in which a normal sinus electrogram is stored as a template. And any arrhythmia is compared to it. And if it is close to that template, it's more likely to be consistent with a supraventricular tachyarrhythmia, versus if it is completely off, it's more likely to be a ventricular arrhythmia. So here's an example. Wavelet here, the match threshold was set at 70. It's looking at each of these beats, and they're really not matching with the original template. Deliver the therapy. Here, wavelet, the threshold 70%, and most of these beats look quite similar, and it would withhold therapy. So that's a way to try to program the device similar to a human. Other programming techniques include using high rate detection cutoffs, like AFib with RVR, for example, might go up to 170 or 180, unlikely for AFib with RVR to be over 200. Detection duration to extend those to allow for the termination of avoidable arrhythmias, as well as forcing timeout periods to off, because AFib intervals can last a very long time. And then ATP should be delivered first on the off chance of actually terminating a ventricular arrhythmia and avoiding the shock. So let's do some stored events. So here, anyone else want to turn on their camera? I promise this will be gentle. All right, looks like, well, we'll ask a polling question. This is an arrhythmia that was present, and it's a fast ventricular arrhythmia that needs detection for VT-REF. And here we see that the arrhythmia is over. So was a shock delivered or was a ATP delivered? We'll go with the poll. What do you guys think? Shock or ATP here? Awesome, terrific. So here's delivery of ATP and then return to sinus rhythm. Okay, so this one, here we've already got the answer on the screen. It's an example here of inappropriate VT detection because of functional atrial undersensing. Discriminators were programmed, but because of the nature of this arrhythmia, 2-to-1, there was blanking of the A channel. And with that blanking, it met detection criteria for VT as opposed to not meeting that criteria. All right, who wants to take this one? Any volunteers? What's happening here?
Looks like noise.
Great. And what do you see that makes you think it's noise?
Non-physiologic our intervals on the RV tip to RV ring.
Perfect. So what Laura is pointing out here is that on the RV tip to ring, there are high frequency signals that are very close together. Even ventricular tachycardias that are fast wouldn't have a signal that's less than 100 milliseconds. And when you see this type of behavior, you have to think, well, maybe my sensing electrode itself has been damaged, or maybe there's a problem with that there. And in contrast, look at RV coil to SVC. Here, we see nice regular ventricular signals. So you can go one step further and you can say, well, I know that there's a fracture, and I know that it's not just a fracture of the lead completely, but that's specifically of the cable that's going to the RV tip or the RV ring, and not having to do with the cable that's going to the RV coil. So you can really kind of minutely diagnose where problems may be occurring. All right. What's going on here? Anyone else want to try this one? Kene, what do you think?
So I think there's like a paced rhythm, and then there's a PVC over that happened at the end that induced VT.
Okay, great. So Mahmoud is saying, well, I see a relatively regular rhythm, and then all of a sudden at the end, I see something much faster. And the two electrodes that we have is RV tip to RV ring and CAN to RV coil. So it's misleading here because you want to think that there's one A and there's one B. But in fact here, this is both looking at the RV.
Mm-hmm.
And what the device sees is always in the marker channel. So you are always smarter than the device. So the device is only going to be able to see what it shows. And interestingly, it's showing VS and then TS, 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 TS. So tachysense, V-sense. So that it thinks that there's actually a tachycardia here. And TD means tachycardia detection has been met. And then actually what we have at the end is the device pacing this arrhythmia. So this is an example of ICD malfunction. There is something wrong here because this doesn't look right to us like VT. So the question is what is this seeing? And so one way to try to answer that question is to say, well, it sees a TS here, what's going on? Well, geez, look at this here. That's the T wave.
Mm-hmm.
So this is an example of T wave oversensing. Everybody see that?
Mm-hmm.
So the device misfired because it saw T waves and thought that it was actually a ventricular signal because it can't tell, right? It's not applying wavelet to every sensed event, okay? And in fact, I had a patient today who came into clinic who had a biventricular pacemaker set at 75, and yet his heart rate was 50 on his EKG. And it was an example of T-wave oversensing in clinic. And we reprogrammed it, got better. A stereotypic sign of T-wave oversensing, if you look at the scatter plot of rates, is this train track appearance. So what this represents is each VV interval. So it sees a VV interval that's just over 300 milliseconds and then 400 milliseconds. Just over 300 milliseconds and then 400 milliseconds. Because the one that's shorter is the T wave. And the one that's longer is the next sinus beat. All right, fifth example. Any takers here? So we'll break this up and we'll say, let me ask this question. Is there one arrhythmia present or is there two? And you can use your chats. Okay, so a couple votes for two. And a lot of like, whoa, whoa, what's going on, I think, right? So some votes for two. Okay, so the A channel, this is the A channel. This looks probably like atrial fibrillation, right? It's irregular, very, very fast. Laura had pointed this out earlier, super disorganized, doesn't look good. Now the V channel, something interesting is happening. So initially, it looks like it's AFib with rapid ventricular response. But then something changes here. So this is an example of a tachycardia inducing a tachycardia. So you can have AFib induce other arrhythmias. And so the device appropriately detected this ventricular arrhythmia. So at this point, this person had VT and AFib. So that's an example of dual tachycardia. This is an example of a tachycardia inducing a tachycardia, and then appropriate function of the defibrillator. All right, so conclusions. ICDs are now routinely used in the automatic identification and treatment of ventricular arrhythmias. A suite of algorithms are utilized to improve arrhythmia sensing and minimize inappropriate therapies. And critical when you have patients come in who've been shocked is to look at those electrograms yourselves. Because in examining those electrograms, you can make the determination whether or not they were appropriate or inappropriate. Okay, any questions here? And I'm just going to get my next talk sort of ready while we're waiting. Any questions?
Yeah, any questions from the group? Again, you can also put some questions in the chat box if you're a little shy and don't want to speak up. Some of these we may answer directly online if we think we can kind of do that without necessarily interrupting the speaker, and anyone could see the answers as well. But sometimes we will also maybe take a question or two directly to the speaker. But I think so far these talks have been superb, and not all that many questions because I think they're doing an excellent job. But again, please don't hesitate. Our next talk will be kind of going back again to the pacemaker ECGs. So again, something that everyone will be seeing just because many patients have devices and everyone pretty much gets an ECG in everyone's clinic or patients on the floor. And we're going to actually see a little bit how to possibly identify the devices and how it's programmed and some of the special features. So, Gaurav, we're set to go?
Sure. Does everybody see a screen this time?
We do.
All right, so we're already in better shape than the beginning of the last talk, which I apologize for having you guys see just the title screen. So this talk is going to be a little bit different than what Gurjit covered. We're going to talk about, broadly speaking, how to approach pacemaker ECGs. And then we'll go into a couple examples. I think that pacemakers and pacemaker functionality is notoriously complex. There are so many different algorithms and algorithms embedded within algorithms about different timing cycles. And so our goal here is to talk first, fundamentally, what are we looking at when we look at a paced ECG? How can we glean specific pieces of information? And then how can we identify when there are potential errors present? So less on specific algorithms and more on general approaches. So agenda, modes of pacing, review of ECGs and pacemaker timing cycles, and examples and special features. And actually, Ralph, if you could tell me, has everyone here just been introduced to the regular sort of pacemaker nomenclature?
Yes, we covered that a bit in the first talk, but again, don't hesitate. A little repetition is probably a good thing.
Great. So again here, so we had talked last time about defibrillators, and then fundamentally pacemakers are quite different, a totally different paradigm. Whereas defibrillators are like fire extinguishers, you only use them when you need them. Pacemakers are there like metronomes. They're always working to try to sustain a specific heart rate. And importantly, even among pacemakers, cardiac resynchronization therapy is unique in of itself. Whereas pacing, the technology was originally introduced to prevent bradycardia, the goal of cardiac resynchronization therapy is something different entirely. It's to try to pace every single beat in order to correct the problem of dysynchrony. So the fundamental concept being quite different, that instead of simply being a metronome, this is a device that actually coordinates. So if we're to say that someone has left bundle branch block, that one wall is always coming in late, and that is the cause of heart failure. If you simply bring the walls in together, the same diseased muscle can make a lot more output. So fundamentally, the goal of CRT is to pace every single beat. Now, the options for CRT related to the ECGs we'll be seeing soon are really multifactorial now in 2021. So here's an example, chest x-ray of a heart, and then there's the heart there. A traditional CRT system is a biventricular pacemaker. So there's a lead that's placed in the right ventricle, and then that's coordinated with the left ventricular lead, which is delivered via the coronary sinus into a tributary of the coronary sinus. Now, failing that, we could always place epicardial leads. Epicardial leads are usually placed surgically. And there's both robotic as well as limited thoracic approaches. Endocardial lead. So endocardial pacing right now is being evaluated in a clinical trial as a follow-up of the WISE CRT trial. So that's wireless endocardial stimulation. Any of your centers, are they doing wireless endocardial LV pacing? Gurjeet is shaking his head, yes, so that's terrific. So are you doing it right now at Henry Ford?
Yes, Gaurav, yeah, we are part of the trial. Mhm.
So this is the, I'd probably say the latest and greatest, and you can only do it at a couple centers. So we'd love to talk offline about your experience with that. His bundle pacing. So his bundle pacing here, the idea is to pace at the level of the his to capture beyond the site of proximal left interhiscian block. And perhaps the most recent approach is to pace the conduction system on the left side directly. So this is called left bundle branch area or LV septal pacing. Maybe if folks can just use the chat function, how many of you guys have heard of left bundle area or LV septal pacing? Anybody using it at their center? A couple people shaking their heads. So that's probably the newest approach, and we'll return to that a bit later. Okay, and here's yet another type of pacemaker. Anyone want to take a guess at what type of pacemaker this is? Okay, bunch of votes for Micra. I love it. So Medtronic branding has done well. This is actually a nanostem. This is an Abbott device, previously St. Jude. This is the one that was actually first commercially approved and released, although is now temporarily sort of delayed due to problems with their battery. Here's an example of a Micra on chest x-ray, sort of floating in the apex there. And what type of pacemaker is this?
His lead.
It's a His lead, very good. So it's a dual chamber device, and there's a lead here in the right atrium. And then there's also a lead that's directed toward probably the top of the tricuspid annulus, perhaps on the atrial side or perhaps just ventricular, pointing almost directly posterior. And so this lead is capturing the His. Importantly here, and this is just a note to orient those of you who are used to looking at chest x-ray, the lateral chest x-ray is really invaluable because it's the only view that we get of the posterior aspect of the heart. And the posterior, of course, is where the LV lives. You know, it's a mistake of history that we call it the right ventricle and the left ventricle. The right ventricle goes to like all the way out here. It doesn't go to all the way here, but it goes pretty far out. But what is really important is that the right ventricle is anterior to the left ventricle. So, you know, we unfortunately think of these things as it being right on this side, left on this side. It's really right ventricle is the anterior ventricle, left ventricle is the posterior ventricle. And when you have leads that are going towards the septum, they should be pointed towards the posterior aspect of a lateral chest X-ray. So good job, that was a His bundle pacemaker. A note on nomenclature, some people call it ECG, some people call it EKG. It's both right, ECG equals EKG. So what's going on with the tracing? When a wavefront travels toward a positive dipole, you get a positive deflection. If you're looking in two planes, if your vantage point here, where the wavefront's traveling towards you, it'll be quite positive. If your vantage point is slightly higher, you'll still see a positive, but it'll be a little bit smaller. If it's on the other side, you'll see a negative because it's traveling away from you. And this actually is how Einthoven's triangle is put together, lead 1s, 2, and 3, 1 right arm to left arm, 2 right arm to left leg, and 3 left arm to left leg. So that composes what's called the vertical plane. The augmented leads are simply mathematical combinations of lead 1, 2, and 3. And then the precordial leads have a different purpose. They're really looking at the horizontal plane. People talk about clockwise rotation or counterclockwise. This is one way to look at that. Again, here you can see that the right ventricle is anterior to the left ventricle. And if you put it together, you get a vertical or a frontal plane and a horizontal plane. And what's missing, of course, here is the posterior aspect of the heart. We don't actually put leads there in a traditional 12-lead ECG, and yet can be quite significant. So now let's launch in with that in mind to look at some ECGs. So what kind of pacing is present here? And anybody can either chime in or use the chat. Good. So AV paced rhythm. And here we don't know if it's DBD or DOO. But here's another question. Where's the ventricular lead? So I'll show it to you again. Where's the ventricular lead? Okay, RV, terrific. So, you know, some of you guys are third-year fellows, so we're going to go one step further. Where in the RV is the right ventricular lead? Good. So there's comments here made that it's an apical lead. And that's because when we look at the inferior leads, 2, 3, and ABF, we see QS components. So right at the apex of the heart, all of the wavefront is going to be traveling from down low to up high. So that's why you have QSs or wavefronts are traveling away from the inferior leads. And importantly here, V1 through V6, all of them are queued out, completely queued. And the reason they're queued is and this tells you just how apical it is that even V6, which is in the same plane as the fifth intercostal space, all the way at the mid-axillary line, it looks like it's traveling away because it's the furthest most tip of the right ventricle that reaches that point. But you can take advantage of this when thinking about lead placement with biventricular systems or also with other lead placements for the RV. So here's another example, pacing what looks like most likely an RV apical lead. Interestingly, positive now in V6, so maybe not be quite as distal. The underlying rhythm here is atrial fibrillation, so here we have VVI or VOO. What's going on here? Good. So it's an example of atrial pacing. This might be AAI, it could be AOO, or it could be DDD, A-paced V-sense, simply with a long AV delay. You can't tell from just the ECG alone. Biventricular pacing for CRT, here's an example of a biventricular pacing system. Again, on the lateral, you can see that this lead here, which looks like it's relatively basal to mid on the AP projection, is clearly posterior. So it's in a nice posterior lateral vein. When we look at the EKG for this patient, and if we zoom in, we can see two pacing spikes. There's one here and then there's another. So those are the two pacing spikes from each of the leads. So this patient was timed where the LV is slightly earlier than the RV. And you can see the LV depolarization artifact followed by the RV depolarization artifact. Here's another patient, came in with 2 to 1 AV block. There's more P's than V's. She gets a pacemaker. What kind of pacemaker is this? She had 2 to 1 block. Good. So a couple people are saying hiss. Good. So it's not that there's ascents and could be pacemaker pseudofusion if she's conducting, but this is indeed pacing and it's non-selective pacing up to this bundle. Gurjit covered this.
Dual chamber, though, that the ones who wrote dual chamber are indeed correct. It's a dual chamber with the ventricular lead by the His bundle. And this is absolutely not like a VVI type device, right?
Correct. That's exactly right.
Everyone?
That's exactly right.
VVI, I just see V pacing.
That's exactly right. This is a patient who has a lead in the atrium that's being sensed and then delivering a hiss at a programmed interval after that.
Right. So see, it wouldn't, it theoretically could be possible that it's ventricular only to be fortuitous that it was exactly the same rate as the atrium and exactly the same reasonable PR interval. So that really doesn't happen. So it must be tracking that atrium and pacing in the ventricle. And remember, the DDD has all of the modes in it. So we could really argue if there was a test question, say what mode is the pacemaker operating? It's really operating in the VAT mode because remember the first letter is pacing in the ventricle, sensing in the atrium, and every time it sees a beat in the atrium, it triggers. Remember that DDD has both atrium and ventricle for the first letter, atrium and ventricle for the second, and then triggered as well as inhibit function for the third D. Great.
Terrific. I'm not going to go deep into pacemaker timing cycles since a lot of this was covered by Gurjit. Importantly here, there's 4 scenarios in DDD pacing. One in which the A and the V are sensed, another is A sensed, V paced, A paced, V sensed, and A paced, V paced. And that the timing is determined by both a lower rate and an upper rate that's programmed by the device, as well as the various intervals that are programmed in. So let's do some examples in sort of our last 3 minutes. And some of these are variations on a theme. So you may have seen variations of these before. Anyone want to try to take this one here? So this is a patient who has a pacemaker, is on telemetry. No specific complaints.
Are we seeing pacemaker Wenckebach again?
Terrific. So how do you know it's pacemaker Wenckebach?
Well, because we can see that kind of like it's a little bit fast to start, but then kind of the P waves seem to move earlier and earlier, and then you see kind of a dropped beat and it kind of resets.
Wonderful. So here you can see the P waves pretty clearly in the precordial leads. And you can try to look and see, well, what's the relationship between the A and the V? And it does appear that it's shifting out with each beat. And so it's an example of pacemaker Wenckebach, which we covered earlier. And it has to do with the total atrial refractory period, and more of it is being taken up with each ascent. So each ascensed event is taking more of that total atrial refractory period. And because of that, you have what appears to be a relative shortening of each VV interval, but a relative lengthening of each AV interval, because more and more of that atrial refractory period is being taken up by the subsequent atrial sense beat. So it's pushing out the next beat. If you'd like to think of it in a similar fashion, it's actually quite similar to the way we think about sinoatrial exit block, Novitz 1, which would have a similar sort of PP shortening with AV lengthening. Okay, this is a movie of an example that Gurjit talked about here. What's happening in this case? Okay, so pacemaker multi-block or mode switch, both of those are examples. But interestingly here, this is 2-to-1 AV block. So it's a variation on that theme of pacemaker Wenke block. So the rate of the A went up just slightly more, and now the A is falling into a refractory period, so it's 2-to-1 phenomenon pacing. So here's one more example. And then I think I'm getting close on timing. I'm happy to have about 5 more, but we can.
I think you're okay to continue going. I mean, for those who want to pull out, be on their own, but we could go an extra 10, 15 minutes. These are great.
Anyone want to take this one? Now that we have 10 or 15 more minutes, we can go back to the crowd here, see if anybody wants to be bold and try to see, to just say what they see.
One response so far in the chat.
Nice. So someone made the observation here, MVP, so managed ventricular pacing. So let's kind of see, well, what the heck is happening here? So first important point is that these atrial deflections, or I should say these stimulation artifacts that you see on the screen are truly artifactual. This is an example of a telemetry recording. So telemetry doesn't know what the pacemaker is doing. It's actually seeing high frequency impulses that are actually quite small and drawing in that spike. And in fact, that's why all these spikes are the same height. It actually has nothing to do with the pacemaker doing. So you can occasionally get artifacts because the pacemaker telemetry is in pacemaker mode, and the patient may not even have a pacemaker. It will draw in these artifacts. So they may or may not necessarily represent the truth. In this particular example, though, they're pretty believable, and we can see an atrial impulse after one. So it's fair to think that, yeah, probably the device is doing something. So here is a stimulation artifact in an atrial depolarization, and most likely an intrinsic narrow QRS. Here's another one, and here's another QRS, and here's a third, and then there's nothing after it. So no impulse at all. Here's another, possibly another atrial impulse, followed by a stimulation artifact in what looks like clearly a pace spike. Stimulation artifact, atrial impulse V, stimulation artifact, atrium, no V. So the question is, and then right after this, we've got probably a missing, either an erroneous stimulation artifact or a true atrial sense signal, and then a V pace, and then we have AV pacing after that. So at the start of the pacing, at the start of the telemetry feed, we've got atrial pacing. Then we have a ventricular pace beat, another series of atrial pace beat, and then it's switched. So the pacemaker here is changing mode. So it's changing from pacing primarily in the atrium to pacing both the atrium and the ventricle. And what is characteristic of AAI to DDD, that transition and managed ventricular pacing, is that you have the allowance of a dropped beat. That's absolutely right. So it's an example of managed ventricular pacing, and here's an example of how the device does that. So A pace, B pace, A pace, there's no V sense, A pace, V pace, A pace, no V sense, and then switches. So there's 2 dropped beats before it will actually switch modes. And then it can switch back relatively quickly as long as there is a conduction check. Okay, so it'll actually stop pacing and allow it. So when you see 1 dropped beat, you don't know if it's malfunction or not. And certainly when you have 2, that's a concern. But when you have 2 dropped beats followed by resumption of pacing, you should think about managed ventricular pacing.
Right. Could you go back? I want to show one other thing. The other hallmark is that you really have on the EKG. Do you have that?
Yeah. And you can actually annotate on this, Ralph. If you go to the top of your screen and go to.
Now, I'm okay. You can drive. I just want to show everyone that the 4th pace beat, look at that PR interval. Okay, look at that AV interval. What is it? It's really, really tight, right? On that 4th beat. Can you just highlight it there with the arrow, Rob?
This one.
Yep, very short there. And also then on the 7th beat, right? Then we have kind of a long PR, we have a drop beat, and we have a really short PR. So why is this changing? Well, that's the hallmark of MVP. It actually gives you a sub-physiologic AV delay. Okay, no one's AV node, except if you have WPW, is actually going to have, to do that, right? So it's making sure that it V paces. So it does 2 things by doing that. Number 1, it shows you that it did sense that there was no beat in the ventricle before it. It's not over sensing, okay? But what it did is it said, I want to show you that I'm in MVP mode by giving a sub-physiologic AV interval on the beat after the drop beat. And then the other thing that it does is if it has a very long programmed AV delay, it doesn't want to wait that long between ventricular complexes, because look at the previous QRSs, right? If it waited a real long time, then we may get like a 2-second pause or so, right? If we had a programmed AV delay that's pretty long. So it doesn't want to wait that long. The person might get a little dizzy. They're probably not going to pass out, but they even prefer to kind of bring it in even a little bit tighter. So that's really the hallmark of the MVP mode. Not only that it allows you to drop a beat, but it lets you know that it did let you to drop the beat, and it's giving the next beat as a pace complex with a sub-physiologic AV delay.
And here's an example of that here, that sub-physiologic AV delay.
Great.
The first return has it when it switches modes.
Exactly.
So what's happening here? So let's break it down. A pace, 5E pace, A pace, 5E pace, there's RVL, LVP. Here, there's A pace and an RV sense. And yet, if we look at the electrogram here, no clear RV sensing. Again, A pace, RV pace, sorry, RV sense. And then what looks like a real PVC, and then back to A pace, 5E pace, A pace, 5E pace. So this is an unusual type of artifact. This is far field sensing of the A pace event on the ventricular channel. And fortunately, it can be easily addressed by adjusting the sensitivity of the V. But one might predict, or one might think that, well, that could be a problem if you have a defibrillator. right? So if you have a defibrillator, you want to maintain your sensitivity relatively low so that you don't miss signals of ventricular fibrillation, which can be very low amplitude. And so when you see this type of error in a patient with a defibrillator, and if you do adjust the sensitivity, and if you adjust it substantially, you would then also want to be aware of the risk of undersensing VF. All right, example 5 here. Let's just walk through it. A-sense V paste, A-sense V paste. Here we have an A paste, and there is a V-sensed event. Okay, there's an A V-sensed event that's occurring, and yet immediately after it, we see a V paste. Here, A-sense V paste, A paste, V-sense, and immediately after it, we see a V paste. That's a little weird. What's happening in this situation? Okay. So comments here, forced ventricular pacing and CRT or protection mode. All good ideas. So this is an example of a behavior that you'll see across devices, and it's called safety pacing. And it's a feature that was developed to prevent asystole due to crosstalk. Okay, so let's unpack what those words mean. So after an A-paced event, the V channel, might, this is a variation of a theme, might sense something that is actually not a true ventricular event. That's crosstalk. And if that would occur and it inhibited it itself, then you would have asystole after A-pacing. And in fact, early generation devices, there were some patients who demonstrated asystole during atrial pacing. And so in the setting of safety pacing, what occurs is that safety pacing will deliver a V-paced beat if a V-sensed event falls within the window in which crosstalk could occur. And it's a very short sort of interval difference between the V-paced safety pacing and that sensed event. In this example, the schematic, there's no true V-sensed event that's occurring here. But what might occur is a PVC, a true intrinsic beat, or nothing at all would induce safety pacing. So it's when you see a pacing artifact that comes at a relatively short AV interval after a paced event. And what you have to look for then is either a V-sensed or a PVC, or it may simply be that the A-paced artifact is being oversensed on the ventricular channel.
Can you show us on that tracing again? Because there was a little question about why that happened on the, yeah, there we go. So what happened? What was the inciting event that was a problem?
What do you guys think? What's different about this beat here?
Yeah, it is AV pacing, but why did it AV pace? What did it miss?
Undersense the P wave.
Right, it didn't sense the P wave. So then the VA clock timed out, right? And it gave an atrial pace. But it just so happened that this person has reasonable AV conduction. So that P wave cause a native QRS, but it was right at the same time of an atrial pace. So then the ventricular channel saw that ventricular sense, but said, wait a minute, I just paced in the atrium. How could I get a V that quickly? It didn't conduct down that quickly. But, you know, I don't think it really is. I could put a ventricular pace down, but if I do, and it really was for some reason a QRS, then I'd be pacing on the T wave. And years ago, we really didn't like to pace on T waves when we had very high output devices. So it said, I'm not going to do that. I'm going to give a very short AV interval pace. And therefore, if it really was maybe that I'm just sensing the atrial spike or the atrial deflection in the ventricular channel, and in order to prevent there to have been asystole, I'm going to pace in the ventricle at a short delay, so I avoid pacing on the T as a regular program device, but I'm going to, you know, pace nevertheless. So a lot of times when you see safety pacing, it may be that you're under sensing the atrium, or it may be that a PVC just happened to fall at that time, or it may be junctional rhythm. Let's say, to make this the question of the night, okay, let's say this person had congestive heart failure, and this is really an only RV lead, right? Because look in V1, it looks like a leftish bundle pattern. What could we really do for this person? Now, everyone could say, well, we could upgrade to a CRT, right? Because that's always the answer. And that would make the device companies happy. But what could we really do for this person to avoid RV only pacing based upon what we're seeing?
Prolong your AV delays.
Yeah, because look how nice and narrow their QRS is, right? They have a nice narrow QRS. So if we gave them a longer AV delay, then they wouldn't pace in the ventricle, right? Because that beat is not paced. That's the atrial spike that's right before that narrow QRS. So the PR isn't horribly long. So if we gave them a long AV delay, then we wouldn't have to upgrade to a CRT. What's the bad part about giving someone a really long AV delay? Well, we might hit that 2-to-1 block rate, but if they're not pacemaker dependent, and this person doesn't look at it like they are, that's probably okay. You don't want them to pace in the ventricle. So this, and if they occasionally did have intermittent heart block, you know, you certainly wouldn't feel good about just giving them AAI pacing if they needed it. But this might be a good person for MVP mode. That would let them go all the way to dropping a beat before it paces in the ventricle. Right, so this is probably somebody looking at it now, I'm saying, kind of a little bit wonder why this person has a pacemaker. Obviously, this is one split second in time, but their atrial rate seems pretty good to me. Their QRS is pretty narrow. Their PR interval doesn't look very long. I wouldn't ventricular pace. I'm wasting battery, I'm causing dysynchrony, and that might lead to heart failure.
Terrific. And I think related to that is you also want to investigate why this wasn't set.
Absolutely.
Yeah, just to make sure there's nothing else going on. But you'll see this, like you will see the safety pacing if you look for it. And it's usually PVCs that are sensed where you see a pacing deflection right after for a patient who, you know, had an unfortunately timed PVC. Okay, I've gone way over. We'll stop there.
Sounds great. Thank you for an excellent talk to all of our faculty. And I just want to remind everyone that the final session will be on Saturday morning. That's 8 a.m. on Central Time, 9 a.m. Eastern, and it'll be the same ID for you to get into the system. We're also happy to answer some other questions. You can email us, any of the faculty, and we'll see how we do on Saturday. And have a good night, everyone.
Thank you so much. Thanks so much for coming.
Great talk, Joe.